Hi, everybody. I'm very excited about tonight's talks. I'm very pleased to introduce three speakers in our COVID-19 seminar. And just by way of mechanics, a couple things. I'm dealing with a family situation, and so I'm going to be in and out myself. But Megan Piotrowski, the TA for the course, will be running everything. So everything should work just fine. I'm very pleased to introduce our three speakers, Dr. Chad Zawitz. Dr. Zawitz is a faculty member at Rush Medical College, specialized in infectious diseases. He is working in correctional health care, and he's the head of the infection control department at Cermak Health Services. He also directs the continuity of care clinic at Ruth Rothstein Core Center. Our second speaker is Dr. Sage Kim, who's a faculty member in health policy and administration in the School of Public Health. She works on the effects of incarceration, health disparities, and population health. And our third speaker tonight is Ms. Robin Fretwell Wilson. She's a faculty member in the University of Illinois College of Law, and she directs the Institute of Government and Public Affairs. I know her because she's leading a very interesting discussion group of faculty experts related to the COVID-19 pandemic. And Ms. Fretwell specializes in family law, health law, and she teaches biomedical ethics, law and religion, children and violence, and law and science. So Dr. Zawitz will speak first, and I would ask you to put your questions into the chat. Megan is going to moderate that, but I think we're going to try to hold the questions until the end so that we're sure that we get through the three talks. So thank you very much for speaking in our seminar, and Dr. Zawitz, take it away.
Thank you, Linda, and thank you to the group. I hope this technology is working and everyone can hear me nice and clear. It really is a great honor, great awesome, I get thumbs up. It's a real honor to have been invited to speak to you. Your program is very esteemed. I'm sure those of you who are on board have vested interest in public health, and I'm hoping my little contribution to that, talking about correctional health and our response to the pandemic, provides you some insight into some of the bigger picture of what's happening behind the scenes. So given the fact that I have only 20 to 30 minutes and a lot of material, I'm going to just dive right in. First, my colleagues listed on the title slide, Dr. Connie Manella is our Chief Medical Officer, the Chair of Correctional Health at the Cook County Jail, and Dr. Sharon Welbel is the Chair of Infection Control for Cook County Health, the main health and hospital system for Cook County. She was a diva and a primary resource for us in our immediate pandemic response, and the three of us and many others were co-collaborators in preparing the information I'm going to share with you this evening. So next, I realize that not everybody is totally familiar with the Cook, nor should be, but in fact, I'm not going to use that slide. Let me go to the next one. First, CHS in orange, Cermak Health Services. We are the health services entity. We are a subsidiary of Cook County Health, or CCH, you see in the bubble. But what you'll notice is all of the Cook County Health, which is Stroger Hospital, Oak Forest, the Core Center, and the community-based clinics, they're all out in the community. Our bubble falls within the circle that says sheriff. So while we are a subsidiary of Cook County Health, that is who I work for, Cook County, we physically are located on the Cook County Jail compound. We do not work for the sheriff, but we work in the sheriff's house. So there's sometimes a misunderstanding that we don't work for the sheriff. We abide by the sheriff's rules, but he does not direct how we deliver health care, and we certainly do not tell them how to run a jail. Now, the jail is not a big building with bars and cells. Our jail is a large compound, more than 90 acres. And what you're looking at, of course, is the satellite view. North, south, sort of divided in the middle is California Avenue. This is the famous 26th in California. You'll notice that there are a whole bunch of different buildings located across this compound. We call those buildings divisions. Each division has a special purpose. So, for example, classification by security, minimum, medium, maximum. Some house men, some house women, some are used for medical, some are used for mental health, some are combination buildings. So you get the general concept. So that's the first thing, is it's not a one-size-fits-all building with bars and cells. Some of these buildings are large dormitories where there are groups of people in a big room and one door. Some of these buildings are the traditional celled units you might envision, where there's two people in a cell, and then an adjacent cell, and there's an upper tier and a lower tier. That's the general layout. And when you start thinking about pandemics and pandemic responses and which type of settings are more conducive to the transmission of a communicable disease like COVID, you can imagine, for example, dormitories are really a setup for the worst possible outcomes. And we were stuck with our physical plant is what it is. The second thing to identify on this slide, I'm spending a little extra time on this because it's important for this talk. The buildings with the red crosses are the buildings that housed patients at the time the pandemic started. So pre-COVID, not all of the buildings were occupied. In fact, some of them have physically been demolished. They're not even in existence anymore. And the rest of the ones that are not marked have other purposes or have been closed or mothballed. They were just empty, vacant buildings with a bunch of empty cells. And that certainly comes in very handy when you need to start social distancing and spreading out the population. We have the luxury of a bunch of empty buildings we had the option to use later on. So in the interest of time, that doesn't add anything to this. This is another slide where I'm going to show you a transition later in the talk, so I just want to spend a moment on this. This is the general flow of how patients enter the jail, what happens when they're in the jail, and then what happens at the time they leave. So starting at the top, you see bond court. Someone is, actually, let me back up one more step. I want to make sure everyone on this program is aware of the difference between jail and prison. It's a complicated answer, but I'm going to give you the short, simple one. Jail means pre-trial detainee. You have been charged with, or you have been alleged to have been, engaged in some sort of criminal act. You have been arrested. You are innocent until proven guilty, and you are in jail to await your day in court, and then your case will be adjudicated. If you are convicted and sentenced, then you will go to prison and become a prisoner or an inmate. So there is some nomenclature or some words that will distinguish whether you're talking about jail or prison. What it does not entail is short stay versus long stay, which is what I think a lot of people assume is the difference between jail and prison. We are a jail. So that being said, you get arrested, you come to jail. The first thing that happens is you get insurance screening. Believe it or not, we make sure everybody has the option to enroll in Affordable Care Act before they're released so they can have a medical card. Then everybody who stays in custody at that point would go through a comprehensive medical and mental health evaluation, and that helped to determine to which of those divisions on that last slide I showed you, you will ultimately be housed. So if you're healthy and don't have a bunch of medical problems, then it would basically be Department of Corrections decides where they're going to put you based on your classification. But if you have additional medical or mental health needs, then our input will influence where the Department of Corrections ultimately would house you on the compound. The middle big blue box just shows you the, quite frankly, vast array of healthcare and other services that we do provide on site at the jail. And then at discharge, we have a robust MAT program, including linkage to community care. And we do the best that we can to ensure our medical patients as well as our mental health patients are linked to community care and services. It sounds great on paper. It's a lot harder and a lot less simplistic than that. And we don't always get everybody linked to care, but we certainly have their best interests at heart. We don't just go, well, they're not in the jail anymore, not our problem, it's society's problem again. We really want to see our patients succeed. Okay. In the interest of time, I'm skipping that slide because we're going to talk about a whole lot more and I don't have a whole lot of time. So everybody probably already knows the timeline of the COVID pandemic, so I'm also going to skip those slides, and I'm hoping the group will have access to these slides later if they're interested in looking at them. If not, I'll figure out a way to send them to you. So forgive me for skipping a couple of slides. The next slide is, what did we do at the Cook County Jail? So a lot of our response started well before, well, quite frankly, before they even declared a pandemic. If you don't remember the timeline, I will remind you that the World Health Organization, despite the fact that COVID was already all over the world, did not actually declare a pandemic until March 11th. So by then, the cat was out of the bag and COVID was already here in the United States, and in our opinion was probably already at the Cook County Jail by March 11th. That being said, we knew it was coming as early as January, as well as everybody else did. So what did we do? Well, we initiated a modification of our intake screening. So it wasn't just, it was flu season, so we're already screening people for flu-like symptoms and taking vital signs. But now it included the CDC and the health department's recommendation to take a travel history. Were you from any of the countries that have you visited recently any of the countries that have had cases of COVID? And that list expanded from January until the pandemic was officially declared. We early on did a PPE inventory to make sure we had adequate supplies and or could get them. We were predicting that the entire country was going to be scrambling for PPE, and everybody knows how this unfolded in the news. People were literally scrambling for masks and protective gear. We checked our supplies. We actually secured some of our more precious supplies like N95 masks. While I know our staff are very well intentioned, we did not want to have our PPE and cleaning supplies, I'll colorfully use the term repurposed from their intended use by the staff and others in specific clinical situations. So we secured our supplies early on. We did a staffing survey. We anticipated that we might need more staff, so-called surge staffing. And we also anticipated it's a pandemic. We are going to lose people to this. There's going to be attrition. And we tried to make our best estimates of how much we thought we would need and or lose. We early on, even before the pandemic, reached out to IEMA, which is essentially the Illinois National Guard, asking for them to be on the ready for us to get surge staffing with them. And quite frankly, they did get deployed to the Cook County Jail for a significant period of time during our outbreak surge. We adjusted our nursing duties. Some of the examples were like giving our patients bigger supplies of medication so there'd be less patient to staff contact over the outbreak, and giving them a squirt of hand gel when they have to take medicines by mouth so they have clean hands. We engaged in even closer relationships with our collaborating partners, and this last bullet point may be one of the most key points to our pre-pandemic preparations. Collaborating with our DOC partners, the sheriff's folks, the sanitarians, and establishing their disinfection protocols. The unions, the jail has to work in a labor situation, so we can't necessarily mandate a lot of things without making sure that the labor partners were on board so they could get the rest of the staff to agree with what we needed to do. Of course, Cook County Health, our local health department, Chicago Department of Public Health, IDPH, and others were all involved. You also see patient advocacy partners, including the Public Defender's Office, advocacy groups, and many more. We were in constant contact with so many well-invested and well-intended parties, and all of this was pre-COVID. A couple other things we did, more clinical. I think the second bullet point is particularly important. We started cohort housing, or you might prefer to use the term quarantine. Everybody coming in on the new, every day we get 80 to 100 new detainees coming onto the compound on average. So we did not, remember, everyone has to not have revisionist history here. We did not have tests for COVID in March. There was no access to testing in early March. The only way and the only place in Illinois you could get a COVID test in March was to appeal to the Illinois Department of Public Health and send a specimen to one of the state labs. And the only way they would run a test is if the patient met the CDC criteria, which is travel to one of those countries plus symptoms. So since 0 of our patients were going to meet the travel history, but we had a congregate setting, when it ultimately came time to do testing, we actually had to appeal to the state to get our first tests run. So what could we do? Well, we could take all the people coming in on the new and quarantine, house them for 14 days. In other words, keep them, they are technically the community coming into the jail, sequester them so that they do not expose the population at large within the jail, in hopes that we could prevent some introduction of the pandemic into the compound from newly incarcerated individuals. We got shelter in place. We had a modified version of what was happening in the community. If you remember, the governor put in the shelter in place order, and we all basically were told to stay home. Well, in the jail, what that meant was we reduced unnecessary movement on the compound. Again, many people might assume when you're locked up, you just get put in a cell and you stay there until you get taken to court or whatever. But the truth is, as you saw by that blue box a couple slides ago, we have a vast array of services. Our patients are constantly moving from their cell to programming to you know what within the compound. And there's a lot of opportunity for mixing of patients. There's a lot of opportunity for exposure to staff who might have it. So anything we can do to reduce movement on the compound, we were using a term modified shelter in place. Okay, whoops, next slide. Next slide. Okay, so I showed you the map of the jail, and I mentioned one of the things, there are certain so-called pillars of infection control, and one of those pillars is social distancing. Well, when you're incarcerated, everyone, I think, also envisions a bunch of people basically piled on top of each other in crowded, stinky, dirty, dark cells, and that's not totally inaccurate, although I think it's a bit of a more of a cinema fantasy to describe it like that. But what we had the luxury of was those empty buildings that I mentioned earlier. So once it became clear that we were dealing with a pandemic, one of the first measures the sheriff took was to essentially reallocate and open up those closed buildings, and that's what the green crosses represent, empty buildings that were opened. And what that allowed us to do was single cell almost everybody on the compound, with the exception of folks who were in the dormitory style living units. And by increasing, social distancing, you reduce the risk of transmission. So one of the pillars of infection control was achieved by having the luxury of extra space on a compound. So as our outbreak began, I gave you the story already that we had a case in mid-March and we wanted to test them. And the only way we could do the test was to send it to the state lab, and they said it doesn't meet criteria. And I actually had to pick up the phone and call the Illinois Department of Public Health State Lab. I talked to the lab director in Carbondale, and she said, "Oh, congregate setting, jail, we get it, we understand. Sure, we'll run your test." However, the turnaround time for our first test, we sent it on March 18th, and we did not receive our result on the first test until March 28th, 10 days. So ask yourself, what can you do in 10 days when you're waiting for a test result? And the answer is not a whole heck of a lot. In the interim, from the time we sent the first test on March 18th until we actually got the result back, we had more than 100 confirmed cases, because 2 days later, March 20th, Cook County Stroger Hospital had the ability to either run the tests or contract it out through a commercial laboratory. So we had the ability to send tests outside of the health department 2 days later, and the turnaround time for all of those tests that we submitted starting on March 20th was between 1 and 3 days. That's how we knew 100 confirmed cases between the presentation of the first one and the result of the first one. Okay, I'm going to skip that slide and get to one of my favorite slides in the whole talk. This is, with emphasis, a real illustration of almost exactly what happened at the jail in terms of this pandemic. The gray line represents, of the tests that we submitted, what was the percent positivity rate. So when you hear, for example, in the news, Chicago or Cook County's positivity rate went up from 6 to 7 or 8 or whatever the percent is right now, that's saying if Cook County did, I'm making this up, if Cook County did 50,000 tests today, what percent of those were positive? And then you can do the math, how many cases that represents. So what you see is in the beginning, starting in mid-March until roughly maybe mid-April, a large percentage of our tests were coming back positive. But I want you to keep in mind that at that point in history, the only people that were meaningfully getting tested were PUIs, people with symptoms. So we didn't know, and most people didn't know at that time, how much transmission was probably happening and with asymptomatic or pre-symptomatic transmission. So we also did not have the ability to test asymptomatic people or do surveillance early on. That's why the rate was so super high in the very beginning. But you'll notice that percent positivity plummets down very quickly starting in mid-April. And that's because by mid-April, we then began to introduce surveillance testing. We had increased expanded capacity, and the guidelines for whom you could test changed to allow you to test a broader swath of the population and not just the symptomatics. That's why you see the percent positivity start to plummet. The numbers at the top of those bars are the numbers of tests that were done in that week. So you can see ever since we started surveillance in the middle of April, the numbers of tests per week that we've been doing at the jail has been increasing at a fairly steady clip. We're now averaging anywhere from 1,200 to 1,500 tests a week on it. And you'll also note that our percent positivity after the early surge has dropped down to, hovers around 1% on average. And that has been sustained since roughly the end of May, all the way up until the present time. We still only have about 1% of all the tests we're running testing positive. And that is despite the fact that the community test positivity rate has been at its lowest since the initial surge, about 3.5%. It's now somewhere around 7 or 8%. So how does Cook County Jail successfully mitigate and then contain, excuse me, let me get that, I got that right, mitigate and then contain the outbreak? How did we do it? Well, it was the pillars of infection control. It's not a vaccine, it's not magic, and it isn't even staff testing. This is not staff testing. This is detainee testing. We had social distancing. We layered in universal masking. By the end of March, we started having everybody on the compound masked. We had unlimited access to soap and water for the detainee population as well as hand sanitizer. So just simply implementing the basics of infection control is what led to what you're seeing right here. This is not magic, and this is not, there's no treatment, there's no vaccine. This is just simple following of infection control policy, protocols, excuse me. This slide is just a numerical breakdown of what you saw on the last slide, and so in the interest of time, I'm going to skip this. Testing, long story short, is we now, unlike in the beginning of the pandemic, have the ability to test just about anybody compound. We test everybody at intake, so we don't just separate quarantine them when they come in. We test everybody not once, but twice. Once when they enter the jail. Anyone who's positive at the time they come in, we isolate them so they're not exposing anybody else. Their cohort is quarantined for 10 to 14 days. We retest them again at 10 to 14 days in case somebody might have been incubating at the time they came in. And if they're all negative, they're cleared. If someone is positive, we quarantine that group, and then they're held for another 14 days and they're tested again. And we'll keep doing that until there is no more transmission within that group. We also protect our specialty medical areas by doing additional testing around any admissions. So it's almost like a hospital. Before you get admitted to the hospital, in most cases you're getting tested for COVID now. Before certain procedures and specialty clinics, we're testing. Physician care, meaning anyone who's going to get, for example, transferred to the Illinois Department of Corrections, we are testing them before they leave. We do not transfer people who have COVID to the prison system. When we have not been doing that, the only caveat I can say is we did not start the prison transfer testing protocol until a little later in the pandemic. So it's not that we've been doing that all along, but that is not in guidelines. That is not a CDC recommendation. That is something we do in addition to everything else to increase the protection for the prison system, because we certainly don't want to be exporting COVID either to the community or to the prisons. Patients can request tests, so they don't even have to be sick. They can be nervous or worried or want to get a clean test before they're discharged home to their loved ones. They can get tested. And there's a number of other examples of who we're testing. Okay, home stretch. So key points. What do we think worked? Well, we don't believe there was any one single containment or mitigation measure that had the most impact, but we think the most critical things that worked the best were one, testing, test, test, test. Test as many people as you can and have the shortest turnaround time. And that's kind of common sense. But early on, when we didn't have the capacity to test, that was part of what hindered our initial early response. We were chasing it down early on. Number two, the cessation of movement or the shelter in place. Number three was the expanded footprint or the social distancing, and we had those extra buildings to do that. Number four was universal masking, and number five was separate housing at intake. So it wasn't just testing at intake, but keeping them quarantined. Those are the big five. There were other things, many other things we did, some of which we think may have been impactful, but probably less so. That included removing fomites, modifying our existing cleaning and disinfection protocols with the sanitarians, doing temperature checks and screenings. But notice I didn't say testing of staff. You'll see, I'm not saying staff aren't getting infected. I didn't actually include those data. We don't have access to, for example, the sheriff's testing data. But what I can tell you is there is no regular routine testing of the medical staff, the nurses, the medics. There's no regular testing of the officers. And despite the fact that we aren't testing the staff, you can see that we have contained the spread of COVID on the compound. And that's without testing, just doing temperature checks on entry. And then, of course, the hand sanitizer. I won't read these to you because you'll have access to them later, but I just want to highlight the footer on this in the next couple of slides. The CDC has available guidelines on the COVID pandemic for a variety of settings, as well as the community at large. They also have specific guidelines available for the management of coronavirus correctional settings, and that is the website at the bottom. That's the link. So you could just Google CDC COVID corrections. It'll take you right to the website, and you can read, because there are definitely specifics and nuances the CDC addresses that are of interest in a correctional setting that wouldn't matter, for example, in a nursing home. They are both congregate settings, but nursing home patients don't have to go to court. That's just a bad joke and a bad example, but just to give you an idea, there are a lot of things that are nuanced about correctional settings, and the CDC acknowledges that by giving us their own set of guidelines. So there are 4 slides giving you a bunch of examples of what they do. Last thing I wanted to mention, and then I'm going to stop, is we cannot underestimate the importance of our data analysis and leveraging our technology. For those of you who are into the stats, and since this is public health, I imagine some of you are statisticians or really like this part of it. And I tip my cap to you, because your brethren are the ones who enable us to utilize our technology in the most effective way to monitor our chronic diseases, know where our most vulnerable patients were, pulling statistics, giving reports to the health departments, and so many other aspects of our public health response all came from our ability to leverage our technology. Last slide, I promise, and that was that initial slide showing you the flow. Everything in red are things that were in some way or another modified or changed due to the pandemic. You can see the testing not once but twice before they actually get housed in the jail proper. A number of our services were modified, and we had a robust discharge and transition of care process to make sure we were not exporting COVID to the community. And if someone had it and they were going home, we wanted to make sure they knew what to do to protect their neighbors. Okay, so I'm cutting off a couple. Oh, one last thing. That's what I do. I lie. This is a preprint article written by myself and some of my colleagues at the jail, some CDC field team agents who were deployed to the jail, our Cook County Health partners, some corrections partners, and Chicago Department of Public Health partners. And it, in much more detail, outlines our outbreak response that I presented to you today. So if anybody is interested, that is the title of the paper. That is the link that'll take you to the paper. And I'm going to stop and let the next presenter jump on board. And sorry for going over a little bit, and thank you.
Thank you so much. Thank you so much. Apologies if you can hear me. So, we will just go right into Dr. Kim.
Yeah, hi, I'm Sage Kim from Health Policy Division. So I am going to focus on what's happening in prisons. Ted just sort of talked about the difference between jails and prisons, and just so you know, this presentation will sort of overview Illinois Department of Corrections, mainly prisons. So I sent you a link to our initial IGPA policy report on COVID transmission in prison settings, which was published in early July. The primary motivation of this report was concern that correctional settings are vulnerable to COVID transmission, and without preventive measures, prisons can easily be the site of COVID outbreaks. So that was published in July 6th, I think it is. At the time we were working on the initial report, there were actually only 274 confirmed cases among inmates and additional 187 cases among staff throughout 16 IDOC prisons out of 29 facilities, excluding treatment and transition centers. So since then, IDOC COVID cases have increased exponentially. Actually, IDOC saw over 400 positives in the week of August 11th. So that was the second week of August. That was the beginning of this dramatic increase in the number of cases among inmates and staff that's currently actually going on. By mid-September, the number of cases quadrupled since July, since our first report, to over 1,300 cases among inmates and an additional 658 positives among IDOC staff. And as of October 27th, so it was yesterday, the day before yesterday, there were 2,000 and some 200 confirmed cases among inmates in IDOC, which is another sort of 69% increase since September. And there were more than 1,100 cases among IDOC staff, which is another 70% increase since September number. And it seems like COVID infection now are going on in 28 IDOC prisons, so that too from only 14, I think, prisons actually saw COVID infection. So just so you know, overnight between Tuesday and Wednesday, I was looking at the numbers, October 28th, so additional 65 inmates and 53 staff positive cases were added to the IDOC COVID website. So it's actually moving really fast. So what happened, right? One thing I can think about is that COVID cases have been increasing all throughout Illinois, especially outside of Cook County, right? So that might have the, staff exposure. In fact, there was newspaper clips talking about 18 IDOC staff went to a retirement party and they got exposed to COVID infection. So that's one thing. So overall, Illinois is experiencing increasing COVID cases. The other thing is that IDOC resumed county jail intakes on August 3rd. Remember, on March 26th, first COVID case was confirmed in the Illinois prison system, and so inmate transfer from county jails were suspended with an executive order. It was order number 11, I think it was. And then on April 10th, admissions of inmates to treatment programs were also limited. So there were pretty much like no sort of prison inmate transfer amongst prison system and from jails in Illinois. But then a lawsuit was filed in July on behalf of county sheriffs against Governor Pritzker and the director of the IDOC, challenging governor's authority to suspend transfer of inmates. And following the court order, IDOC had to now, IDOC is required to accept inmates from county jails. So that was the first week of August, and then you see cases began to spike following the decision. And between August 3rd and the end of September, according to the IDOC spokesperson, there were more than 2,400 transferred from jails to IDOC facilities. And now governor is appealing the court order. So we'll see what happens, right? But it really is a catch-2 because limiting transfers from jails to IDOC still creates a crowding problem for jails, right? Without reducing admissions to jail, it's a very difficult situation for jail. So just so you know, jail admission have been increasing during this time. For example, Cook County Jail had just over 5,600 detainees in February. So that was official sort of number from Cook County Sheriff's Office. And the number went down to 4,600 by July 1st. But since then, the number of detainees had been steadily really increased to about 4,800 on August 1st to 5,300 on September. And as of October 28th, there were 34 detainees in Cook County Jail. So the numbers, close to the before COVID level. And, you can see why, because, in Chicago, we've been having a lot of gun related arrests happening, and, protests also, contributed to more arrests. And so the number of people being arrested seemed to actually increase during this period. But interestingly, IDOC population has been gone down substantially. So before COVID, there were 38,000 people in IDOC prisons, and now the last survey census data that published by IDOC actually showed it's about 30,000. So there's like over 8,000 reduction in terms of IDOC population. So the Marshall Project reports the number of COVID cases in prisons by state. Overall, close to 153,000 confirmed cases have been reported in state prisons all over the country, and more than 1,200 people died. Texas, Florida, and California prisons have highest COVID cases, but Arkansas, Kansas, and Tennessee have highest infection rates. See, these prisons tend to have relatively higher incarceration rates than the national average. For example, Kansas incarceration rate is at about 900 per 100,000, which is higher than the U.S. average, which is below 700 per 100,000. Tennessee incarceration rate is also high at about 850 per 100,000. Texas, same thing, over 890. And Florida, too, their incarceration rate is greater than 800 per 100,000. In terms of Cook County COVID cases in Illinois, Illinois rate is higher in the middle, sort of overall Illinois population, but Illinois prison COVID rate is right in the middle of and nationally, but still the COVID case rate in Illinois prisons higher than overall population. So the overall Illinois case rate is at about 300 per 10,000 people, but it's over 670 for IDOC. The number of tests done in IDOC is significantly lower than in the general population. I think this is a problem. Chad talks about the importance of testing in Cook County Jail, but it doesn't seem like a lot of tests that were done in IDOC. It looks like it's about 12,000 tests so far for 30,000 inmates. This is about 25% lower testing rate than the overall Illinois testing rates. The positive rate is also very high in the IDOC. In July, with just over 1,000 tests, the positive rate was reported 31% in IDOC. In September, the number of tests increased to about 1,000, and the positive rate went down to close to 16%. Now, with just over 12,000 tests, the positive rate actually started to go up. So now it's over 19%. So nationally, a couple of prisons have done mass testing of prison inmates, and these prisons actually saw widespread infections among inmates. For example, Ohio State Prison System, which had several outbreaks in April, and then it started mass testing of all staff and inmates, and they found that 70% of inmates test positive in April, but after mass testing, now there are just over 200 inmates in Ohio prisons are positive. The key is that Ohio State Prison System decided to test everyone, including people with no symptoms. North Carolina prisons also took a similar approach to Ohio, and they also found 65% of inmates being tested were actually test positive, and of these, 98% were actually asymptomatic. But in IDOC, an IDOC spokesperson described in a newspaper interview that testing is still limited inside prisons, so they test only people who display some symptoms. So just to summarize, here's a comparison of case rates. First, I want to note that not all IDO facilities have high infection rates, but some of the prisons in Illinois truly are having exponential increase of COVID cases between July and October. For example, Jacksonville prison, initially when we're looking at the numbers, there was only one staff test positive and 0 inmates. But now there are 215 staff and 117 inmates test positive. Same thing with East Moline. When we were writing the report initially, there were 28 inmates had COVID. Now it went up to 267 inmates on October 27. And Stateville was already having cases in June, but now there are over 300 inmates and 162 staff confirmed cases in Stateville. And Logan and Menard are also having significantly more cases now. Okay, so this thing is not going. All right, so can you go to the next step? I have the map. So I actually mapped the zip code level Illinois COVID rate and overlaid with the location of IDOC facilities, and that would. Okay, that's not working. So comparing July 1 and October 27, you can see there those 5 IDOC facilities with significantly high COVID cases now, and these prisons are actually located in zip code areas with sort of fast-growing COVID infection in the general population. And then there are a couple of prisons with lower infection rate currently, but in these areas, these prisons are located in areas with relatively high COVID infection in the general population. So there's, potential possibility that community infection could affect the prison cases in these areas. Can you flip it now? No. Okay, so just the last slide that I want to talk about, sort of what could be done, right? So we initially suggested a couple of strategies to deal with COVID in correctional settings, and I think these are still important to consider. First, we argue that basic public health in prisons needs to be improved. This healthcare access and quality has been an issue even before COVID. And secondly, inmate release is urgently needed to address crowding in prisons. And third, testing is still a problem in Illinois prisons. And finally, sort of keeping social ties with family and friends is important to reduce mental health burden. All right, so I'm going to stop and have, hand it over to Robin.
Thank you so much, Dr. Kim. Sorry that the slide is not advancing. I will make sure we can get Robin's presentation up. So, also, we will make these presentations available to the class after. So.
Perfect. I'll have a little coaching about how I find, again, the slides to advance. So I go to share.
I pulled up your presentation.
Okay, files.
Yeah, there's an arrow at the bottom. I think you got it.
Yeah, I don't know this Blackboard version.
Yeah, there's the arrow to the right, just above the icons at the bottom. I think you should be able to move that.
Yeah,
Working.
Share now. Well, it looks like it's thinking. Give me half a second. Hopefully it thinks faster.
Sure.
Or I'm happy for you to do that if that's less cumbersome.
Yeah, I can advance the slides if you want.
Maybe that would be best, so we don't
Okay.
take a bunch more time.
Sure.
Some of this will be new. Some of this will be new to you. Oh, that didn't come through as well as I would have hoped. I'm not sure how that happened, but so some of you may not know much about the Institute of Government and Public Affairs, so I'll just make a mention of it. SAGE has been collaborating with us, but it's a primary vehicle across the whole of the University of Illinois system for putting faculty and their research into public policy conversations. If you want to go ahead and advance it, or I can do that. So SAGE has been drawing in part on the policy spotlight that we did together. I think of these as kind of public policy down at eye level, where you can, suggest some things that lawmakers might do now in real time to make things better. One of the, I thought, great insights that SAGE brought to this policy spotlight was to say, look, there are good reasons that we should focus on prisons because risks inside the prison might seep out to communities, and things that are happening in communities may then get inside the prison or other congregate care settings like nursing homes. And so we're like kind of all in this together. And she also suggested on this very critical question of PPE, could we direct the PPE to places in a kind of thoughtful way to try to contain pandemics? So there are some really easy to execute ideas in the policy spotlights, and I think that's giving us explains why they're having the kind of uptake by lawmakers that they've had. Can you go ahead and advance? Not just lawmakers, by the way. We've been really pleased to be able to talk about some of this work on CAN TV. So you can see Sage here. And some of these reporters then have gone on to do more work under the umbrella of Injustice Watch about what's happening with prisoners. And in a separate project, if you'll go ahead, we have been trying to introduce some of the people who are concerned for what's happening inside the prison, trying to help them get a kind of handle on the human element. Stuff, Sage, new to you, I think. So I have two projects in particular that are drilling down on that human impact. One is a project that I'm doing with Ruby Mendenhall at UIUC, who's shown on the left here. She wears like a bajillion hats, including the Dean of Diversity and Inclusion and this type of thing at the College of Medicine at UIUC. And then Jason Mazzoni, who's my colleague at the College of Law. That's where I was before taking the new position at IGPA. So if you'll go ahead, I'll show you something about each of these projects as they relate to what's happening inside the prisons. So this is a citizen scientist journaling project that I'm doing with Ruby. You can just sort of see from the 17 people journaling with us a lot of diversity across the state, including something I'm especially proud of. We have a former inmate who just came out of an IDOC facility, and we have a gentleman who's in IDOC right now who, with a variety of very creative mechanisms, has been writing on the regular for us. And I'll show you some of Leo's. That's Leo Lacey. You see the blue circle, that's him shown there, and he's in Taylorsville. Go ahead, please. So some of this work, just a little plug for us, we have these amazing folks like Jamie Dunn Thomason, our communications director here. You may not know this, Sage, but she's managed to get us a kind of shown regularly on a show with NPR Illinois. So we're very happy to have that. And some of our citizen scientists are now reading their entries. We hope to be on this show regularly. So if you'll keep going. So this is Leo. Leo's inside the Taylorville Correctional Center. And, it's sort of eye-popping after hearing Chad and then looking at the numbers of statistics that, Sage has shared. It wouldn't be very surprising if you had outbreaks in these facilities. And the reason why is if you look at what Leo says, skip down towards the bottom, and I'll read it for you a little bit. It says, well, COVID-19 pandemic first hit when it first started, the governor put all the prisons on a level 1 lockdown. And you can find, by the way, his entries at our citizen scientist journaling page. I'll put it in chat in a few minutes. He goes, people like himself, live in, and this is like the 4th paragraph, dorm setting. And in the dorm setting, there are 20 men in a room and 100 men per side in the 2-room housing unit. And we share a community restroom that has 5 toilets, 2 urinals, and 10 sinks. Now, all of those folks funneling back to the same common space, you can instantly see from what that that's going to be a kind of risky thing. And other places, he writes a lot more about this, that, people were supposed to be wearing their PPE and they're not in these dorm settings because they're like their homes and it gets old fast. And so some of the things that we think as a matter of high-level policy are happening to contain risks doesn't really quite work out that way. So I'd invite you to see some of his stuff there. He, now that Emma has moved from Can TV to Injustice Watch, we have been running a little interference between the two of them while she interviews him. And then we're posting his answers after she does her exclusive work with Leo. So that's Leo. We'll keep going. We also have a gentleman who, Lloyd DeGrain, who you see on the bottom here, who has been helping us reach out to members of the homeless community. But I share one of the he's a photojournalist, so he's photographing the people who are writing for us. And so you can see here this gentleman who shares his story about having to get out of jail in prison, sort of dropped out the front gates, given $20 and told good luck with that and given a bus ticket. And it's a really compelling story about how he managed to get back to Chicago. Lloyd's known him as a member of the homeless community for a long time. Lloyd ends up taking him for a meal, and he writes for us. And he starts talking about how he got back from Austin all the way to Chicago by hitching a ride with someone who turned out to be a police officer. And so he sort of, at the end of this entry, talks about how the police officers, some of them can be good people too. And, you know, he said, I accept that now the cops, they're just like the rest of us. And it's a really actually interesting account of knowing a person from a really long ride and how that can be a kind of healing in our society. So that's like the citizen scientist journaling project, who's our person inside the jail and the homeless community, and some other insights even just about how's all this going down for real people right now. And then on the other side of this, if you'll advance the slide, we have a new project that's about access to justice and COVID in particular. And the reason I mention this, these are the 4 people working together, including Andrea Miller, who you see in the middle here. I'm also a part of this project, by the way, but including Andrea Miller, who you see here, who's now at the National Center for State Courts. And we are doing focus groups in Illinois, in-depth focus groups in South Carolina, which is an interesting pairing by itself, and then shooting at a national survey. You'll keep going. I'll show you some of the people that we've been talking with. The reason I mention it here is we have Supreme Court justices that we have been speaking with, including Justice Rita Garman. The Supreme Court matters for the purposes of a lot of what is happening in the criminal justice system right now that people are struggling with. We've had really, really positive feedback from the judges, from litigants. We're speaking with jurors tomorrow who have had to be in jury trials, masked, and you know, how is that working? One of the big themes, if you go to the next slide, is what happens with what we call speedy trials. So, you know, you have the right as a criminal detainee or as a detainee. And it was great that Chad mentioned, you know, people are assumed to be innocent, right? You have the right to a speedy trial. You have the right to have your stuff solved, and then you get out of jail, okay? And so one of the things that Justice Gorman and the left is talking about is how the Supreme Court of Illinois is the one who is charged with figuring out what does speedy trial mean during COVID. And one of the things that she specifically talks about is this sort of balance of how do we keep the jurors safe so that people can have their criminal trials, and then how do we get them, you know, their speedy trial to which they're due. And so they've issued a number of orders around this. I think they're really, really interesting. This is not yet on a web page, so you're seeing work that we haven't presented anywhere else actually until today. And then she starts talking about how, you know, the court started attacking very heavily towards Zoom trials, just like the kind of thing that you're having here right now, so that they can get people through, you know, get them their due process, right? Get them heard, and if they're innocent, get them released. Now, on the right is a gentleman that I've been partnering with in all kinds of things, Mike Nairheim. He's the Lake County State's attorney. He's a super interesting person in the sense of being very think outside of the box. How do we get people, you know, heard and treated well? And do we always have to implicate the system? And so he talks about early on in COVID that the police were basically just issuing summonses and then letting people go. And they did a very long process of clearing out the jails so that it was only detainees that posed a risk potentially of safety to the community that were being kept there. Because being kept there was a risk to people. And especially it would be ironic if you were innocent and you're kept in this place where, you have a very, very high risk of contracting what could be a deadly disease. He also talks about the fact that there's been an innovation in cooperation with the Supreme Court to have bond hearings now heard. So the person, the detainee, is being heard by Zoom from the jail. So no one has to take them from the jail anymore to the courthouse. It has saved a huge amount of manpower that can be better spent on other things because, there are a lot of things happening in the court system that are requiring more sanitation and that type of thing. And they're not taking a deputy or a bailiff away from that work while they then go to the jail to get somebody for a bond hearing that could be done virtually. So we're seeing some innovations. One of the things that we're really getting out of our conversations and deep dives with folks like Mike and with Justice Garman and others is what are those things that COVID has forced us to do that can be innovations that we keep? And I think that's the end of this. I'll go to the next slide. And that's really the end of this, so you can stop sharing slides. I hope that's helpful. That's just a point that I have to go over.
Thank you so much, Robin.
Yes.
This was helpful. I was actually wondering, how some of the inmates or prisoners had been reacting to COVID and certain measures. So this is our last speaker. I think I'm going to just go ahead and jump right into some of the questions that have been popping up in the chat. And yeah, these will go through all three presentations. So our first question is from Katya Hardy. She asked, as a physician in a youth setting, I think this may have been to Dr. Zero. As a physician in a unique setting, do you have any input with administration, the justice system regarding encouraging alternate placements, i.e. monitoring for low-level offenders to keep the jail population as low as possible?
I wasn't sure who that was directed to.
I honestly could only hear bits and pieces. There was a lot of in and out, so I apologize, but I could barely hear the question.
Well, sorry about that. Is this better?
Much.
Okay. I have a second monitor that I was looking at. First question, if you can see the chat, you could read it there as well. As a physician in a unique setting, do you have any input with administration, justice system regarding encouraging alternate placement like home monitoring for low-level offenders to keep the jail population as low as possible?
This is Dr. Zaywitz from the jail. I still only heard part of it, but I think it was asking about, there's some weird feedback going on here. Is everyone else hearing that?
No?
Yes, it's really bad.
Well, what I think I heard, I'll try to do my best to answer. It was a question about alternative sentencing and the utilization of electronic monitoring and other ways to maybe augment decarceration. I'm hoping that was what the question was. Yes, okay, good. Well, I can't completely answer, but what I can say is people who are in jail custody, getting them out of the jail is a court-mediated process. So the sheriff has no ability to release people. He can't go, well, Dr. Zaywitz, who are the sickest, most vulnerable people? Tell us who they are and we'll let them go. It doesn't work that way. We can tell him that, and he could plead with the judges, but ultimately, decarceration has to come from the court level, unless I have a complete misunderstanding of the criminal justice system. The sheriff runs a secure environment where they are detained, but when they come and when they go is determined by the courts exclusively. So when we had, and I mean it in the nicest possible way, when we had protesters and all these very well get the jail population down, marching up and down the jail, and I kept thinking, why aren't they marching outside the courthouse and not the jail? Because the sheriff can't let them go. So that's my sort of slightly charged answer to a great question.
And this is Robin. I'll jump on the end of that because I think, Chad's exactly right. One of the things that we have heard that's incredibly innovative in the courts project is teams of folks at particular places. So it'll be the administrative judge, it'll be the individual judges that are running specific courtrooms and specific dockets, together with the prosecutors, together with the public defenders. All talking about how can they thin the ranks of the people who are sitting in jail. That happened at Lake County. We're hearing that happening in South Carolina and other places. And some of the stuff has been really interesting because some stuff you just go to jail for, right? But you might have been put in jail for at a prior time, like, I don't know, driving recklessly, right? Unless you seem to be posing a risk to the community, they are just releasing people on recognizance bond. In other words, out you go and come back when it's your turn, but not holding you in the jail where that might pose a risk to the public. So I think there's a lot of innovation happening here. I agree with Chad completely. It's not within the purview of the sheriff to do, though. It's really a question of the prosecutor together with the court. In some places, it's actually the prosecutor who decides what to schedule for trial. That's true in South Carolina. And even the judge couldn't do that without the prosecutor.
So the other sort of side of the story is that, currently Chicago Police Department is going through, consent decree, right? So the key idea is, unwanted police encounter and hyper surveillance in minority communities. So if even before people end up in jail, if you don't have this kind of highly racially, sort of skewed, charged, surveillance in minority communities, we could have actually reduced people who are arrested in the first place. And I think, we'll see what happens with the CPD consent decree, but, the external monitor group actually finished this in their first survey with community members, including over 900 people. And I am, involved in another sort of qualitative sort of portion of this, but I think this is a bigger story than just people in jail and people go protesting for jail. That like Chad said, that's not going to solve the problem. But if we step back and think about overall sort of criminal justice practices that have been very long time, highly racialized, that need to be sort of addressed.
Thank you, Dr. Kim. Can you all hear me better? Okay, great. Sorry about that earlier. Thank you. It sounds like this is a very complicated issue and a question. The next question is, some news reports are stating temperature checks may not be a good indicator, but you mentioned temperature checks on a regular basis. Is it still prudent to conduct regular temperature checks?
Well, I guess, I mean, to be quite honest, I feel like temperature checks is safety theater. That's probably not the answer I should be saying in a big public forum like this. We, it is advised to do symptoms and temperature checks, and that's why you see it done, and that's why you see it done in stores and restaurants and other environments, airplanes, all that. But whoever asked the question, the scientific answer is it's, in my opinion, pretty useless. My understanding so far, since we implemented temperature screenings at the jail, is they've detected exactly 0 people with a fever, and they've probably done tens of thousands, maybe more than 100,000. I don't know. They've done so many temperature screens, 0 fever. So to me, it's safety theater.
You have something to add, Robin?
Well, so that's alarming. But one of the things that we learned in having a focus group with a judge that I'm sorry, the chief administrative clerk for a chief judge in South Carolina, is this particular courthouse had not had any stops or interruptions to their work because of an outbreak. And the very first thing the guy bought was like this standalone temperature check thing. And knock on wood, he believed that that was one of the things that really mattered because they were able to screen out the public. Now, maybe the answer about the safety theater differs depending on whether you have a contained population or you have people coming and going. I don't know. But he swore by it. And I think they paid for it with CARES Act money, which is a super interesting point. And I'll tell you, there are some other innovations happening in Illinois where they've cannibalized conference rooms inside of a courthouse and set up like monitors so people could attend virtually hearings because they can't go to the courtroom because that's unsafe right now. And it kind of lets them bridge the digital divide, and they did that with CARES Act money. So it's kind of interesting, some of the innovations. I'd be curious though, Chad, is that safety theater when you got people coming and going, or is it the containment of the people that makes it not so helpful?
Well, I think it's helpful if someone has a fever, but my experience is that the vast majority of people who have COVID are asymptomatic and have no fever. So it's going to detect that 1 in 1,000. I'm not saying it's completely useless. I just think that it's effectively completely useless because it doesn't detect all the people who are asymptomatic and don't have fevers. We do it, and it should be done, and I'm not saying don't do it. I'm just saying I don't believe that it has a meaningful impact on COVID prevention, at least at the Cook County Jail. Maybe there are sites and settings where there's better utility. I've visited my father in the hospital, and I know they check temperature like even better than they did at the jail. They had a better thermometer opinion, but anyway, that's my thoughts about this. That's why I said safety theater, because it doesn't detect what I think is the majority of the possible cases that could still be entering the compound. And I'll second that with even a symptoms screener. While it's better than nothing, it's not going to detect asymptomatic people. It's not going to detect people who are symptomatic who lie because they ran out of sick days because there's a bad policy about, being able to take time off in a pandemic or something. Whole other can of worms. But I caution that you should do these things. I just don't know that they meaningfully prevent the disease being brought onto the compound. That's all I meant by that. So forgive me for, I tend to speak a little off the cuff, and okay, good, we're good, okay.
I think that's an important point because, now that applies to many other, congregate settings, including dorms and schools. And also I noticed also that the UIC, coming into my office, sitting in my office, all you had to do is temperature check and symptom checking, right? So who else out there in this building, fine, but might have something, right? So I think, as we were actually, looking at school, college-based, COVID issues that we were looking at with Ron and people, I think this is something we need to really review what needs to be done. It can't be just like we feel good. At least we did temperature check.
Thanks, everyone. Hopefully there'll be studies coming out to see if it's been effective. The next question is, how can we in public health push the issue of incarceration? If this is kind of a repeat of the first question, we can kind of touch on it briefly. If you have more input, please.
I mean, I might not be the best person to answer. This is more of a policy question, but I guess maybe if one of you two have a better perspective on what a public health advocate could do. We certainly advocate for our patients, but we're right now, especially, we're just day to day on the front lines trying to provide them health care, and it's hard to find additional time to bring our message. This is so great to have, 70 or 80 brilliant minds on this call who have the ability to have this influence on a bigger stage than what I can do at the little Cook County jail or the big Cook County jail. So I'll pass this baton to one of you two. Maybe you could better answer it, please.
What was the question? I didn't hear.
What can you do to advocate for decarceration? We talk a little about that in the policy spotlight. Do you want to pick up on Ohio and Rikers there, Sage? Or
Yeah, and also I think that I keep going back to sort of, since you're students mainly, thinking about this as not just what happened with COVID and do we need to, how many people we need to release, because of COVID. But I think we need to think about why we are actually incarcerating so many people for so long in the environment where, Robin, you can talk about the consent decree in 2019, right? So, not only incarceration, somebody actually mentioned stigmatization and criminalization issue. Also in this environment where, healthcare is, difficult to get quality care, and so Robin, you want to talk a little bit about the consent decree related to healthcare providers and the director, what was that? The person in charge of medical care in IDOC wasn't even a medical person.
yeah, so there was a long litigation and a special call out to the ACLU for pursuing this for a decade. It put pressure on IDOC to look at how they were treating prisoners in their care. Now, there's a legal duty anytime somebody's in your custody to, it's a special duty because you have them in custody to make sure they're well. So generally the government doesn't have a duty to help people, which seems backwards. But when they're trapped and can't help themselves, a duty sort of arises because they're in your special custody. But that's not always a very thick duty. It's really, really hard to recover for that. The ACLU brought this litigation, and then there was a consent decree where both sides agreed that there was more that could be done, which is better sometimes than trying to individually secure, settlements or awards through individual litigation. Net is that there's a medical monitor who looks at what's happening within IDOC. There were some structural problems, as Sage says, so that they had like a review committee about whether you needed something, but it looked like there was interest, like who the person on the committee might not be a physician, they might have an interest in the economic outcome of additional services happening. So they've kind of cleaned all of that up. Where we use it in the pandemic in prisons is to say, look, there are specific things that have already been agreed to in just the last little bit of time that might help with COVID, like looking at why people are dying in the facility. Was it COVID related? Was there something that was preventable? That type of thing. Now, to Tasha's point, and I'd actually be interested to hear from Tasha about what happened at North Dakota State Penitentiary. But there was some advocacy that we talk about in the pandemic behind the bars spotlight, specifically in Ohio, where they released like everybody that was in prison, and in Rikers, where they released a lot of people who were medically fragile. And I think those were the kind of conversations that Sage and Chad were talking about. They had to be like the parole board and other people all talking, right? And there's not like the head of the penitentiary solely and singularly could do this. So I think a lot of this is worked out by negotiation with everybody agreeing to that. And I think the first bit of focus has been on elderly folks. Now, Sage did a really nice piece in the pandemic behind the bars to look at the rise in inmates at the IDOC facility who are over 55. They're going to be one of those groups at high risk where we might try to clear them out first. Tasha, did you have a different kind of experience in North Dakota?
Oh, sorry, it sounds similar to that. The patients that are inmates, residents as they're called there, were looked at as far as like when their parole date was coming, and they worked closely with the parole board to see if they would indeed grant those early releases. And then administration actually came to medical and said, this is what we're trying to do for you to be better able to care for COVID in the prison. So what patient or what residents would you be most enthusiastic about getting out of here knowing their medical conditions? So patients with like advanced HIV or full-blown AIDS or cancer, especially cancer patients who are being transported for like treatments on a daily basis, like for radiation, that represented a risk for them getting out into the community, which granted, North Dakota didn't have a lot of cases until this month, seemingly, but it was really helpful.
Well, actually, I got involved in, sort of calculating and estimating sort of a risk factor for inmates. So somebody contacted me, I think it was a Baltimore prison, and someone from IDOC also wanted to do that and looking at risk factors and age, combined. So there was, effort, to think about that way in IDOC as well. But I don't know what happened after that, right? And just by following the census from December to September, the percent of people who are older than 65 remains just about 3.5%, so it hadn't changed. So, but then there were like 8,000 people, got out of the prison. So who are those people? Are they sicker but not really old, older folks, so it's not really clear how to understand this.
Thanks, everyone, and thanks, Tasha, for sharing your experience. There's a question for you, Dr. Kim. It looks like, why do you think there's such a paucity of testing in IDOC when IDPH has so many community testing sites?
I don't know, but actually that triggered, sort of my response to that question was, let's actually think about this in terms of structural violence. So we've been talking a lot about, I'm part of the Center for Health Equity Research, and the whole thing of that center is to think about structural inequality as a form of structural violence. So when you think about violence triangle, before violence becomes actual direct physical violence, it's more structural inequality that actually produces ill health and even death, right? But structural violence, so what I'm saying is inequality, structural inequality is not just a naive term. It's actually a form of violence in sort of, it eventually brings about and legitimizes actual physical violence. And we've seen this since like July, with all kinds of things happening with and social sort of issues and protests and uprising. And so I don't know, I think in not just the testing but overall health conditions, access to care and quality care in prison systems, and what sort of risk people are subjected to just because we're in a certain setting, right? But remember, the majority of people in IDOC are African Americans, right? Compared to majority being whites in Illinois, the general population. So we know already this, sort of a lot more, minorities end up being in prison, but also we do know in the general population, sort of racial inequality in COVID infection and death too. So how does it actually contribute to overall racial inequality in Illinois too? So sort of rambling.
No, thank you so much for that, for your answers and responses. So, last question. A question I had, kind of related to the temperature checks, if things like that aren't, it's not clear if they're effective, but we know more testing is effective. Have either Cook County or the Illinois Department of Corrections been doing any rapid testing, saliva testing, just en masse?
Well, I can speak to the Cook County Jail, and I don't know if you specifically meant for staff or if you meant just at all, but we have been using rapid tests since mid-April for all of the new incoming detainees on the new intakes on the compound. So every night, 80 to 100 people are entering the jail. So every night we use a rapid test on 80 to 100 people so that we have a result back, usually the same night, and that limits any meaningful amount of time that if they're positive, that they're mixing with the population. We have a couple of other testing scenarios where we do use the rapid test for our patient population, but we're not using it for staff at this time. And you had asked about saliva or other types of testing, and the short answer is no. We receive our resources from Cook County Health, and we have to utilize platforms that are aligned with what the health system provides us. So right now we have the Abbott ID Now rapid test kit. Someone I see popped up on the window saying that mandatory staff testing at juvenile. In fact, I understand that it's Roseland that has been, not Roseland, Loretto or Lawndale Christian. So I know there's an organization that comes in and does the testing for the staff at the juvenile center, but at the main jail, we do not have routine testing for staff right now. We have talked about getting I can't remember the name of the test kits, but they're the antigen tests on the cards from the health department. That's a possibility, but those tests I think they're not as precise as the PCR tests. So to be continued on additional testing modalities at the jail. I can't speak for what the prison's doing.
Thank you. Dr. Kim, is the prison doing anything different?
I do not know. Robin, we tried to contact IDOC people. We didn't really get, actual data from them. All we got, I think it's interesting because the question is, IDPH is in charge of IDOC testing. We should be able to get the data, right? But we don't have the data.
Dr. Kim, I can attest to, since we're talking about testing, I know that IDOC at the receiving center at NRC in Joliet, they do use rapid tests for their new intakes as well, but I'm not sure outside of the NRC if they're using rapid testing in other settings.
Thank you for answering that, everyone. I don't see too many more questions in the chat. Dr. Forrest, do you have anything to add? Or does anyone want to raise their hand and ask a question? Dr. Forrest had joined again. I just know it's about 7 when class time ends. I wanted to, be cognizant of everyone's time. If there aren't any more questions, and do you all have any closing remarks you'd like to add?
I just want to thank everybody for honoring us with the ability to share our stories with you. We, we know how complicated this issue is. We're all fighting the good fight. We all have unique perspectives that are complementary to each other, and it's sometimes really easy to get siloed in your role. But like I said early on, part of our success came from our collaboration with a variety of agencies. And as public health experts, you're going to have a great understanding of just how important and how complex the interactions are between all of these organizations. So, good luck with your careers, and I'll pause and see if the other presenters have any final comments. But thank you very much.
This is Robin. I'll go next and give Sage like the pride of last session. But I just populated a citizen scientist journaling project. So if you want to sort of some insights into how it's going in there in real time, you can look at that. And then I will, as Sage is saying, put a link to where you can find the task force work that's done and other people on COVID-19. Sage?
Yeah, thank you. It was interesting talking to you. And also, I think, I will encourage everyone to actually think about this as a long-term sort of issue rather than just handling COVID, because, hyper incarceration and surveillance, it's been, an important issue that we have been battling before COVID. So thank you.
Well, thank you so much for joining and your presentations and for the discussion. This was really appreciated. And have a good night, everyone.
Thank you.
Thanks all. Hey guys, Linda, and would you make sure that Tasha reaches out to me or has my email so she can? Because I think she might have exited just as I'm trying to get that to her.
I'm actually here. I'll email you right now.
Yeah, do that. Hey, I want to pick your brain, okay? And maybe sometimes I have virtual coffees with people and we can chat, but I'd love to, just today I was talking with some folks about trying, and maybe is Sage still on here? I want to tell Sage this too, but trying to do a kind of quick during COVID, Illinois did these things that were really